Looking at the hand and wrist, and I understand the text is really small on the slide, but what we're going to do for hand and wrist in terms of plain film radiograph is we're going to do a PA view, we're going to do a lateral view, and sometimes we're going to do an oblique view. And specialized views, and we're going to talk about these, we're going to do something called a scaphoid view. We're going to do a radial and ulnar deviation view. Those should remind you of something like a stress view. And then we're going to do something called a clenched fist view as well. So in looking at these, what I want you to kind of realize and kind of appreciate is what sort of pathology we're going to see with each of these, when we're going to use each of these views when it comes to the hand and the wrist. So this is obviously a PA view of the hand. Pretty easy. Should be able to identify each of the structures shown here. Obviously we can see a lot of things with this hand and wrist view. Here are all the structures we're going to see with the hand and wrist PA view. So just be able to identify those. Just be able to identify obviously all of our carpal bones, all of our metacarpals, all of our phalanges, and really take a look at the difference between the radius and the ulna. This is another point where I want you to pause the slideshow presentation. I want you to be able to label all of these structures. So get very comfortable and very proficient with labeling these structures. Like I said earlier, there's going to be a large portion of the final exam that's going to be labeling structures. This is a hand lateral view. Obviously very different view that we're going to get with an AP view or a PA view. What I want you to be able to do as well is identify those structures. You're going to see on the next slide we're going to have another opportunity to look at all the structures that we can see with the lateral view of the hand. So taking a look at all the structures we can see, obviously what we can see is we obviously can get a very good picture of the thumb, decent picture of the radius, decent picture of the ulna, but please understand the limitations here. We get a decent view of the first metacarpal, but we can't really see any other metacarpals. Same thing with the phalanges. So just be aware of the limitations of each of these views. This is another opportunity where I want you to pause the slideshow presentation. Obviously you have the answers right here, but just be able to identify each of those structures. So kind of a specialized view here, and this is what we're going to see sometimes with the lateral view, is something called the radial lunate angle. So what we're looking at here is we need a dorsal angle of around 70 degrees, ventral angle around 30 degrees. And really what we're looking at here is we're looking at literally the angle between the radius and the lunate. What this can show us is this can show us instability. So when we look at A, that's going to be our normal. Look at B, and what we have here is we have the entire distal section shifted. And then what we have in C and D is obviously a rotation or instability of the lunate on the radius. This is an oblique view of the hand. Obviously we need to have a special foam pad so the patient can rest their fingers and keep the hand in that position. I can tell you that I broke my thumb when I was in PT school and they did not have that special pad. So I had to hold my hand up on its own, and I can tell you that it hurt something fierce. So here are the structures that we can see on an oblique view. Again, we get just a little different perspective, especially of the metacarpals and phalanges. So what we can see sometimes is sometimes you're not going to be able to see certain aspects of the phalanges, certain aspects of the metacarpals, especially with that lateral view. But then remember, one view is no view. So if we can't see something with a PA view, then sometimes we're going to have to use an oblique view as well. Think about your patients that get things like metal stuck in their hands, or a piece of pencil lead, or maybe there's an avulsion fracture and we need to see where that bone is. Sometimes this oblique view can just give you enough of a tangent that you can really get a good idea for where the structures are. So again, another point where I want you to pause the slideshow presentation, get very comfortable with labeling images. Obviously, this is going to look very, very similar to a PA view of the wrist, but just get very comfortable with looking at this image. Now, number 14 has a little question mark by it. Think about that. What possibly could that be? So, looking at special views, we're going to have a couple different stress views, and these stress views are going to be an ulnar deviation view, a radial deviation view, and honestly, those views look very similar and have a very similar concept to like the stress views that we saw with the neck. We had a flexion stress view, we had an extension stress view, very similar concept. The other concept is actually going to be specialized for a scaphoid fracture, and that's called a clenched fist view. So looking at specialized views, obviously what we see on the left-hand side is going to be an ulnar deviation stress view, and on the right-hand side is going to be a radial deviation stress view. In looking at scaphoid x-rays, really what we need, and this is where we as physical therapists really need to be aware of these clinical signs. Snuff box tenderness. Our patient comes in, hey, I'm having a lot of pain right in that anatomical snuff box. If they're having pain around the scaphoid tubercle, or if longitudinal compression, or axial compression or axial loading is causing pain, well, we really need to be proactive with identifying those and being proactive with trying to seek out a specialized view for potentially a scaphoid fracture. If all three of those are present, that's pretty darn good sensitivity, 100%. Specificity, still about 74%. So really kind of commit those three signs to memory. So here's a little case vignette. We got a 20-year-old male cadet, 1 day status post, acute left wrist pain. And what happened was he was bench pressing and the bench press bar slipped. This one happens unfortunately a lot. What we found was that he was having some dorsal hand and wrist swelling. Range of motion was severely impacted. He was point tender over his scaphoid and he had pain with axial loading. So go back a slide and think about those clinical signs and symptoms and think about that presentation. When you get done with that, move forward to the next couple of slides and we'll talk about what the answers are. So looking at this view, we see a little bit of fracture line right at the scaphoid. And that's exactly what was happening with this individual. Was he suffered axial loading from the bench press accident, which then caused a scaphoid fracture. I will say that this is typically going to be one view. We're going to typically get another view on top of this. Remember, one view is no view. As you can see from the big blue arrow, not that you guys needed it because you guys are all experts now, but that fracture line right at the scaphoid, very indicative of a scaphoid fracture, obviously. So we got another x-ray ordered. We actually took a look at the PA view, and we can see a nice big fracture line happening here. So just be aware of how these views can work. Be aware of the clinical signs and symptoms. Like I said, a lot of this course is decision making. We're going to use diagnostic imaging as a way to see what's happening on someone's insides without an invasive procedure. So just be aware of these things. So as you're moving through this material, study it in a way that, okay, if I was going to see this patient, how would they look? What things would I test? What clinical signs and symptoms would I use? What ACR criteria would I use? Because that really is going to make you most informed in your decision-making process. So scaphoid fracture is the most common bone fracture of the carpals. This one goes missed a lot. Reason it's so important is because it can lead to avascular necrosis of the scaphoid if it's not fixed or if it's not immobilized. So really commit this one to memory. Really think about this one, because this will be a situation, and I have seen it multiple times in my career, where things just get missed. Either the x-ray didn't pick it up, or x-rays weren't ordered, or something other of the sort. And a lot of times you're going to be that provider that actually picks up on those pathologies. So there are different types of scaphoid fractures. These will follow the other fracture classifications that we've already gone over. So if we have a distal third fracture in the scaphoid specifically, that's called a distal pole fracture. The waist is going to be in the middle, and the proximal pole is basically going to be the proximal third of the scaphoid. Scaphoid also has various different directions of fracture, so just be aware of those things. So looking at the clenched fist view, this is going to be a specialized view for the scaphoid. Basically what it is the PA view, and the patient clenches their fist. What happens is that we actually create axial compression. So we actually kind of take the flexor digitorum longus, flexor digitorum brevis, and use it to our advantage to actually create compression. What will happen if the scaphoid is unstable, meaning that there's a fracture there, or the scaphoid lunate interval is unstable, you will see a gap that happens. So the clenched fist view is most commonly known by the eponym the Terry Thomas sign. Terry Thomas was a comedian in the 50s and 60s. I've heard he's very funny. I will be perfectly honest with you, I have not seen any of his work, but he is most commonly associated now with a gap at the scaphoid lunate junction. So looking at hand and wrist trauma, Colles fracture is going to be the most common fracture of the wrist. What that is a distal radius fracture with dorsal displacement of the distal fragment. Okay, so make sure you understand that. I understand that this is an eponym, and obviously this is the reason that eponyms don't work so well. But Colles fracture is what a distal radius fracture is called, with dorsal displacement of the distal fragment. Usually it's going to happen falling on an outstretched arm, or what we call as a Fuchs injury. This is what a distal radius fracture with dorsal displacement looks like. As you can see, PA view, we definitely can tell there's a fracture, but we can't tell what direction the displacement is. This is exactly why we need that lateral view, so we can actually see the displacement. This is a distal radius fracture on MRI. Obviously, the area of darkening is going to be the area that we have the fracture located in. So you can already see the limitations here of using MRI to diagnose fracture. Honestly, it takes a long time. That patient's going to be in that MRI machine for 45 minutes to an hour. It's going to be very expensive. And we can't tell the direction of displacement. All we can tell is that a fracture is there. So really and truly, for this mechanism of injury, MRI has some use if we really, really need it, but we're definitely going to use that plain film radiograph as the first line of defense. So a Smith fracture is a reverse Colles fracture. So all it is a distal radius fracture with palmar displacement. Again, going to use lateral wrist view for this because PA is not going to give us a ton of information. So one of the big things we need to note, and especially we need to ask our patients, is not only how did you get hurt, but how did you fall? Did they fall with full wrist extension, or did they fall with wrist flexion? Honestly, that's going to give us a lot of great information as we're making our decision, because what's going to happen is a lot of times that patient's going to have either a PA view or an oblique view or maybe just a PA. And we really need to understand the mechanism of injury in order to fully understand the osteology and the pathology that's happening. We've gone over this fracture in the past. So this is a Torus fracture that is under the classification of the Salter-Harris fractures. So what we have here is we have a buckling of the bone. Typically it's going to happen in children. Reason being is because that bone is going to be so soft. Here's another couple pictures of a torus fracture. Again, we get a lot of information from a PA view, but also realize that a lateral view is going to have a lot of benefit as well. This one's kind of interesting. This is a 39-year-old male, fell on outstretched arm, complains of dorsal and wrist pain, and what we can see here with the arrow is we have basically an avulsion fracture happening, also with a little bit of dislocation of one of the carpal bones. So what I want you to think about here is how we can better view that, because this picture is not great. So if you haven't figured it out yet, the hand and the wrist are rife with eponyms. So a couple common fractures that we're going to see in the metacarpal specifically, boxer's fracture is a fracture of the fifth metacarpal specifically, and doesn't take too much to realize why and how that happens. Obviously, boxers come down, they punch with their hands, obviously, and they, a lot of times, as they are scraping their hands across the opponent's face or body, a lot of times the actual loading at the fifth metacarpal will cause a fracture. Bennett's and Rolando's fractures are fractures of the first metacarpal. So boxer's fracture, obviously what we're going to look at here. Now we can see this a lot of times with the PA view. A lot of times we're going to need a oblique view as well. Remember, lateral view is not going to help with this, because lateral view, we're going to have so much attenuation and overlap from the metacarpals that we're not going to be able to see the fifth metacarpal. So looking at a Bennett fracture, what we're going to see here is a fracture of the first metacarpal. So we can see the fracture here at the base of the first metacarpal. So just kind of understand and realize and start thinking about how that fracture can happen, how that fracture would present clinically. And then as you can see, a lot of times these fractures can be missed or misdiagnosed because of how small they are and sometimes how they will hide. So looking at very common finger fractures, there's something called gamekeeper's fracture, and that's going to be an avulsion fracture at the ulnar collateral ligament at the base of the thumb. Another fracture is going to be a volar plate fracture, which is going to be an avulsion fracture of the middle phalanx of the palmar surface. So very common, both can happen. We will see these a lot with our finger patients. So gamekeeper's fracture a lot of times will result in something called a Stenner's lesion. And what that is an avulsion fracture of the base of the first phalange origin. And basically what it is that the UCL, or ulnar collateral ligament of the thumb, gets entrapped. What the mechanism of injury is usually hyperabduction of the thumb. So in other words, falling with your thumb out in abduction. So in looking at another picture of a gamekeeper's fracture, just be aware how that happens. Be aware of the mechanism of injury and the involved anatomy. This is obviously a lateral view of a finger. As you can see, there's a very small fracture that's happening at the base of let's call it the interphalangeal joint, or the middle phalanx. So this is a very small fracture. Obviously, you can get a good appreciation for how often these are missed. So as physical therapists, we just need to be very aware of how these fractures can be missed. And this is really a big point on how to listen to your patient and why listening to your patient is so important, because these things will get missed a lot. What I would like you to do at this point is go way back to DPT 5200, Human Anatomy 1, and look up swan neck and boutonniere deformities. Obviously, we can see some swan neck and boutonniere deformities here, but try to understand what happens with a swan neck specifically at each joint, and what happens with the boutonniere specifically at each joint. Obviously, we see a very different presentation with each of these pathologies. Last slide is a slide of rheumatoid arthritis. So just understand how this looks, understand how it looks versus osteoarthritis. Obviously, we see deformity in each of the joints, but we also see a widening in the concave surfaces between the phalanx and each of its articulating surfaces. So just be aware of how rheumatoid arthritis looks versus osteoarthritis. Obviously, rheumatoid arthritis is a more systemic disease. It's going to have a bilateral presentation in most folks. But just be aware of how rheumatoid arthritis looks versus osteoarthritis.